Inflammatory bowel disease is a chronic, idiopathic condition characterized by an aberrant immune response directed against the gastrointestinal tract. Clinically, it encompasses two primary phenotypes, ulcerative colitis and Crohn's disease. Patients with either condition can present with identical extraintestinal manifestations, such as large joint polyarthropathy, episcleritis, and pyoderma gangrenosum. Yet they are distinct clinical entities requiring entirely different long-term management strategies. This cross-section illustrates the core anatomical axiom. On the left, ulcerative colitis is a continuous disease strictly confined to the colon's superficial mucosal layer. On the right, Crohn's disease is a transmural, full-thickness disease, striking discontinuously anywhere in the digestive tract. To understand how to manage these conditions, we have to evaluate them across three domains. We will contrast their histopathology, stratify severity using objective scoring, and deconstruct their opposing surgical algorithms. This anatomical distinction determines the entire clinical trajectory, dictating whether a patient receives a curative resection or localized tissue-sparing management. We begin at the microscopic tissue level to examine the distinct inflammatory infiltrates, starting with ulcerative colitis. This mucosal biopsy of ulcerative colitis shows marked infiltration of plasma cells and the formation of cryptabscesses. The architectural distortion is severe, but the damage remains strictly confined to the mucosal and submucosal layers. The inflammatory profile changes entirely in Crohn's disease, as the immune response targets deeper tissues. Here, in this photomicrograph of Crohn's disease, we see deep mucosal ulcerations driving straight down, breaching the mucosa and causing full-thickness structural damage. This high-power view reveals the pathognomic feature present in roughly 60% of Crohn's patients, the non-caseating giant cell granuloma, forming directly within the inflammatory infiltrate. This difference in microscopic depth dictates the entire clinical course. Superficial crypt abscesses result in mucosal bleeding and fluid loss, whereas deep transmural fissures cause complex, penetrating organ damage. When we scale up to gross surgical pathology, these microscopic features manifest as visible systemic organ failure. This resected colon demonstrates the defining macroscopic trait of ulcerative colitis. Notice the featureless, continuous tubular structure of the resected colon. It always involves the rectum and progresses proximally in a continuous sheet. The gross anatomy of Crohn's disease is characterized by highly localized zones of intense inflammation, completely separated by perfectly healthy tissue. In this specimen of colonic Crohn's disease, there is a sharp delineation between the inflammatory stricture in the center and the normal, unaffected mucosa on either side. These healthy interruptions are known as skip lesions. Examining the mucosal surface of the terminal ileum reveals deep longitudinal ulcerations intersecting with edematous tissue. This creates the classic cobblestone appearance. Because the transmural inflammation of Crohn's reaches the outer serosa, it triggers a reaction in the surrounding mesentery. You can see the mesenteric fat wrapping, often called creeping fat, encroaching over the thickened wall of the ileum. These macroscopic pathologies dictate their respective mechanical failures. Ulcerative colitis results in a rigid, continuously inflamed tube prone to massive dilation. Crohn's disease results in focal fibrotic strictures and fat-wrapped blockages. Because Crohn's disease physically breaches the full thickness of the bowel wall, it frequently presents with complex penetrating complications. This resected specimen shows multiple enterocolic fistulae tracts connecting the terminal ileum directly into the sigmoid colon. Ulcerative colitis rarely fistulizes due to its superficial nature. Instead, patients classically present with bloody diarrhea, tenesmus, and intense urgency. Accurate colitis assessment moves beyond subjective symptoms, relying on standardized clinical metrics to identify early systemic toxicity. The Truelove and Witts matrix stratifies ulcerative colitis severity. Severe disease requires over 6 bloody stools daily, plus systemic markers like tachycardia or fever. Fulminant disease means over 10 daily movements, continuous bleeding, and marked toxicity, warning of impending crisis. Patients with fulminant disease carry an extreme risk of progressing to disintegrative colitis and toxic megacolon. This supine plane radiograph shows toxic dilation of the transverse colon, measuring over 6 centimeters in diameter, complete with mucosal thumbprinting. Cross-sectional imaging provides exact anatomical detail. This CT scan of a pancolitis flare shows significant colonic wall thickening and inflammatory stranding throughout the colonic mesentery. Identifying a progressive increase in colon diameter via these parameters is the explicit clinical trigger to abandon medical therapy and proceed to emergency surgery. First-line management relies on medical optimization using 5-aminosalicylic acid derivatives, immunosuppressives, and targeted biologicals. However, when disease becomes refractory or neoplastic dysplasia is detected, surgical intervention is mandatory. Because ulcerative colitis is strictly confined to the colorectal mucosa, complete surgical removal of the colon and rectum eliminates the diseased tissue entirely. It is functionally curative. In acute severe colitis, an emergency subtotal colectomy is performed. This anatomical diagram illustrates one approach to managing the remaining tissue in a critically ill patient, closing the rectal remnants subfascially at the pelvic brim. Alternatively, as shown here, the rectal remnant can be brought out directly to the skin surface as a mucus fistula. Both techniques avoid the risks of deep pelvic dissection in an unstable patient. This vector schematic shows the elective endpoint for many UC patients, the restorative proctocolectomy with ileal pouch anal anastomosis, or J-pouch. This achieves the cure of a total proctocolectomy while preserving continence. The surgical reality of Crohn's disease requires the exact opposite approach. Crohn's is a panenteric disease, capable of striking anywhere in the gastrointestinal tract. Therefore, there is no surgical cure. Surgical intervention is strictly reserved for managing severe mechanical complications, such as draining abscesses, repairing complex fistulae, or removing fibrotic strictures that resist endoscopic dilation. The core philosophy for Crohn's surgery is strict bowel conservation. Surgeons utilize highly targeted segmental resections or strictureplasties to preserve intestinal length and prevent short bowel syndrome. Surgical success in IBD relies on recognizing that ulcerative colitis is an organ-specific disease requiring radical resection, while Crohn's is a systemic disease demanding maximal tissue preservation. Ulcerative colitis features superficial mucosal inflammation in a continuous distribution. Its severity is evaluated using the Truelove and Witts criteria, and it is curable via proctocolectomy. Crohn's disease features full-thickness transmural inflammation with discontinuous skip lesions. Its fistulizing and stenosing behaviors require highly localized, bowel-sparing symptom management. These two radically divergent clinical pathways stem from a single variable, the pathological depth of the inflammation. This integrated framework, from histopathology to surgical outcome, provides the objective basis for accurate stratification and the precise delivery of medical or surgical therapy.